Good evening and welcome to the first part of our webinar series with equine reproduction specialist Jonathan Pycock. This evening's webinar will be on the use of ultrasonography to predict ovulation in the mare. As this is a pre-recorded webinar, any questions you have for John can be submitted to hello@imv-imaging.com. I will now hand over to John to begin his presentation.
Okay, today we're going to talk about the use of ultrasonography to determine ovulation in the mare. This seemed a good topic to start with because it's a very common procedure all of us involved in equine reproduction will do on a daily basis, trying to predict when ovulation occurs. And there's no doubt that ultrasonography has proven a really useful tool in helping us do this. And over the next half hour, 40 minutes, I want to try and present some of the information I've learned over the years using ultrasound to try and assist you and give you some little tips and tricks to effectively use ultrasonography to determine ovulation. The format that we've got is obviously as a pre-recorded webinar, so you are able to stop and start the presentation as you want. And I'm going to come to any of you who've been to my presentations know I like to have them as interactive as possible. That's a little bit challenging when I can't actually see you, but I've got the usual sort of interactive slides in here, and it'll be apparent during the presentation if you want to stop those, and if there's 2 or 3 of you in a practice or more, you can talk about what the answer to the questions may be. So I hope as we go through it, you'll see what I mean by that, and we can have a useful 40-minute webinar. Just as a refresher, although we're centering and talking about ultrasound, of course, prior to our ultrasound examination of the mare, we're going to have conducted a manual palpation, a gynecological examination. We may have done a speculum exam as well. They're really important, but we're not going to talk about them today in great detail because today we're talking about specifically the use of ultrasonography and specifically to help us predict ovulation. But nonetheless, as a general introduction, it's very important when we're conducting gynecological examinations, no matter how much your level of experience, that you conduct them in a safe environment and preferably stocks, restraining devices so that the mare can be examined safely and you can concentrate on interpreting the image and you're not worrying about getting kicked or the mare moving and those sort of things. Very, very important. Particularly poignant, I suppose, in the current time is it's a more controlled environment to allow you to avoid cross-contamination and transmitting disease around the place. So the fact you've got the mare restrained in stocks allows a much more controlled environment. And with that controlled environment, I think comes the ability to work in a methodical sequence. And that's really important in equine reproduction in general, mare gynecology in particular. Work in a methodical sequence. And never forget to be careful and gentle with the mares. You are doing an invasive procedure and it is possible to damage the mare. So it's important at all times that we are careful and gentle with the mares that we're working with. So a basic palpation prior to the ultrasound is really important. There are 2 reasons why this is so. The first is the reproductive tract is always shown in diagrams and illustrations, as in this case, as a nicely laid out reproductive tract, a left and right ovary, left and right uterine horn, and the uterine body. But it may not be lying like that in the mare as such. It may be moved around if she's got full intestines or a full bladder. So the initial rectal palpation serves to lay the reproductive tract out such that when we go back in with the ultrasound transducer, we're going to be able to have all the structures in the right place, and this will facilitate our interpretation of the ultrasound image. The second reason is that certainly myself and I think most clinicians, as we're doing the rectal palpation, will make a decision about what it is we think we're feeling. Are we feeling a 35 millimeter follicle? Are we thinking it's a corpus luteum? Are we detecting tone in the uterus? And obviously these palpation aspects of the examination aren't available simply from the ultrasound. So a thorough rectal palpation always should precede your ultrasound exam. The ultrasound exam itself, this is quite an old transducer in the picture here. It was one of my favorite back from many years ago. It sits nicely in the palm of your hand. You can see I fold my thumb over the transducer cable, which sort of anchors it in place. And note that the tips of my fingers are in advance of the rectal ultrasound transducer. You don't want to be sort of pushing the transducer forward without your fingertips in front of it, because your fingertips are what are sensitive, and that'll allow you to know if the transducer is being able to move freely or not. So modern transducers are actually a pretty similar size to this one. So they should fit neatly in the palm of most people's hands. And it's always a good idea to just have your fingertips slightly ahead of the transducer face. Then using ultrasound, it's important to develop a routine. By that, I mean a sequence for which you're going to conduct this examination. Now, it can be whatever you like as a clinician. For me, I do all my ultrasound examinations with my left hand, even though I'm a right-handed person for everything else. And I choose to examine the left ovary first. Now, I'll probably, as I insert the transducer, come across the left uterine horn. I'll aim for identifying that. Then I'll rotate the transducer until I come to the left ovary, have a thorough examination of the left ovary, go down the left uterine horn, join up with the uterine body, keep rotating to move up the right uterine horn, and then come on to the right ovary. And then I'll repeat that examination twice, and then I'll check the uterine body very carefully on the way out. I think this double procedure and the methodical nature of it helps me minimize the risks of things like missed twin pregnancies, failure to detect endometrial cysts, and so on, which we'll talk about in a subsequent webinar. Now, along with being methodical in your examination, it's important to be methodical in your results. It's not a good idea to record your rectal and ultrasound findings on the back of your rectal glove box or a little scrap of paper. It's important to have a piece of paper which, when you come back to examine the mare, be it the next day, 14 days later for a pregnancy check, whatever's, you're able to pull up the mare record. Now, some people choose to do this on an iPad, electronically or whatever, and fair enough, you can do that. We're perhaps a little bit old-fashioned in our practice. We use a printed out piece of paper in a, depending on the size of the stud farm, in a ring binder, and we have that information to hand when we examine the mare. And as the mare's coming into the crush for me to examine, I can flick back and have a look at a record so that it brings back to me, oh, this is what I found last time, or get a little bit of information about what size follicles this mare tends to ovulate from, and so on and so forth. So very important to have an accurate gynecological record. Now, precisely what you put on it is going to be up to you. I, of course, put up the example we use, and it works well for us, but it's not saying this is what it has to be. It's whatever you think will work best for you. We have a little bit of a look at ours. You'll see, normally these boxes are replicated 6 times on each piece of paper, just for ease of understanding. And this presentation, I've just highlighted the one box. You can see the left ovary and the right ovary as silhouette diagrams. What we actually do is, with our pen, or if someone's assisting us making the notes, they'll do it, we write on there important structures. Now, you may think, and in fact the title of this presentation may lead you to think, the only important structure to record in the ovary is the follicle. But that's actually incorrect. I think it's very, very important for us as veterinarians working in the field of mare gynecology to get used to recording the presence, or otherwise, you may not be able to see it, but making some comment about the corpus luteum. That's a really important structure. Whenever colleagues ask me about mares and ask me what I think of them, I'll say, right, tell me, did you see the CL? Is there a corpus luteum present? So always, always note the presence or otherwise of a corpus luteum and the number. Maybe there's one, maybe there's two. Maybe they're both in the same ovary, maybe they're in separate ovaries, whatever. But important to note the presence of the corpus luteum. Then we come on to follicle. And I put any follicle over ? Millimeter. What size do you think we should begin to record the follicle? Now, like I said at the beginning, normally I'd put up an interactive slide here. We can't quite do that. So I put up the interactive slide, but the voting will have to be wherever it was when I last gave this presentation. So we'll work with that. But if you're watching this, as I say, as a pre-recorded session, which I think it's all going to be, you should be able to pause it now and have a think about this if you want a little bit more time. So I put here some measurements: 15 millimeters, 20, 25, 30, 35, or 40. When do you think you should first record the follicle size? Well, there isn't really a right or wrong answer. If any of you are struggling to think, oh, I don't want to say anything, I want to get the answer right, let me reassure you, there isn't a right or wrong answer. Let's have a look then wherever it was people voted for when I was here. 15 millimeters. 20 gained a bit of support. Look, 29% of colleagues said they would begin to record the follicle once it was over 20 millimeters. The majority, 43%, over 25 millimeters. A percentage over 30 millimeters, none at 35 and none at 40, as you might expect. Now, let's just say here, for the purposes of this presentation, we're talking about a thoroughbred mare or a warm blood mare, not particularly heavy draft horses and not particular smaller pony types. You'd have to adjust the follicle sizes. So let's go with, we're either with thoroughbred or typical sized warm blood mares. Now, I would be in the 43% category, but as I say, no right or wrong, but I record any follicle over 25 millimeters. Now, why do we do that? Well, clearly it's because we think a follicle is unlikely to ovulate below 25 millimeters. Not impossible, but unlikely. There is an argument follicles in warm bloods and thoroughbreds are unlikely before 30 millimeters. So I wouldn't argue the 29%, or I would argue rather the 29% of people who said they wouldn't record it till 30 millimeters. Fair enough. You're going to be a bit risky if you're not recording until 35, and clearly 40 millimeters is way too late to begin recording them. Nothing wrong with recording at the 15 millimeter and above stage, but too many of them that will be in a follicular wave, which is going to grow and then decrease in size again, i.e. not destined to be a pre-ovulatory follicle. So it seems to make sense to begin to record follicles from at least 20 millimeters, but I think for most of us, 25 millimeter and above would be a start point. So I record presence of a CL, presence of a corpus luteum, any follicle over 25 millimeters. Now, I want to make a point here that over the years, it's become clear to me, many colleagues, when they're asking whether or not I think the follicle's close to ovulation, they'll say, John, the follicle was 38 millimeters yesterday. Now it's gone to 41. Do you think it's ready for me to inseminate? And I think it's important to make the point that follicle diameter is really important to measure. I'm not saying it isn't important. What I'm saying is it is not an accurate predictor of when a mare is going to ovulate in the 24 to 36 hours immediately prior to ovulation. It's an important concept, this. So I want to explore this a little bit more for you. Here we've got a follicle that's pretty spherical. And if we take the 2 dimensions, top and bottom and left to right, you can see, if you look down the bottom, 2.81 and 2.91. So that tells us several things. Tells us that in a follicle that is pretty much spherical, pretty much a perfect sphere, we only need to make one measurement, the widest measurement, either left to right or top to bottom, because they're pretty much the same. Okay, I've got them 0.1 of a centimetre different, but effectively that's a millimetre, which is neither here nor there. That could just be measuring error. So we could easily have got them absolutely the same. And the second thing is this follicle, it's obviously relatively early in the follicular phase because it isn't yet 3 centimetres. It's just below. So at this, we don't know whether it's day 1, day 2, day 3, day 4 in the follicular phase, but it clearly isn't in the immediate pre-ovulatory stage, or it wouldn't lead us to think that. So at this day 1, 2, 3, 4 of follicular phase, measuring the follicle diameter is really useful, and it's accurate. It's accurate because the follicle has retained its spherical shape. Now, let's have a look at a follicle. It might even be in the same mare, 36, perhaps 48 hours on. How much use do you think measuring the diameter of that follicle is? Well, I don't think it is very much use. I could make that follicle 38 millimeters. I could make it 41, depending on where I put the calipers or the arrows. It's not a spherical shape. That's the point. So when we're in this period of 24, 36 hours of predicting ovulation and it's close, then we've got to move away from this obsession with follicle diameter. We're into things like increased echogenicity of the follicle wall. We're into these small echogenic particles appearing in the follicular fluid. More of them later, because I will come back to those as a subject, because they can be an indicator of an abnormal ovulation. But for now, I want to get the point across that in the immediate pre-ovulatory period, its shape changes, echogenic particles appearing, thickening of the wall, flattening of the follicle across the top, rather than it going from 38 millimeters to 41 millimeters. So I hope that makes sense. Now, I thought this might be a little of an interesting slide to allow us to talk about some of the conundrums we face as veterinarians working with mares to predict ovulation. What have we got here? Let's say we've got the left ovary of a mare, and I've got a follicle there. I've got a follicle which I've measured at 2.68 centimeters. What do we think of that follicular shape? What do we think of that follicular wall? What do we think of that follicular size? Rather than tell you the answer now, let me set the question scenarios for you, and then we'll make sure we cover off those points I was alluding to. I assume this mare has an edema pattern and an open cervix. What am I saying by that? Well, I'm letting you know there isn't a corpus luteum present in this mare. There's no CF. So we've got a mare, and we don't know what a right ovary is doing. Let's say there's no follicular structures at all on a right ovary. But on the left ovary, we have this 2.68 centimeter follicle. But what do you think about the follicular shape? And what do you think about the follicular wall? Might be easy if we just flick back to the big image look. Well, the snag we've got, or the problem we've got, is something which faces us in working with mares. The diameter and the shape aren't exactly linking in. By that I mean, this is a relatively small follicle, 2.68 centimeters, but it's changing shape. It's getting a thickened wall. So we've got one signal saying, oh, this follicle won't ovulate for 2 or 3 days. We've got some other signals saying, this follicle's pretty close to ovulation here. And that is how life happens sometimes. Mares don't always read the book, and we're going to be faced with making a decision. So we've got to make a judgment, which is what we're doing when we're predicting ovulation, when we think the mare will ovulate. So if I gave you these 5 options, which of those do you think is when this mare will ovulate? Now, if we look at what people asked when I last polled the question, the majority figured within 36 to 48 hours. A significant percentage above 48 hours, and a good percentage within 24 to 36 hours, and some even within 12 to 24 hours. And there is an argument to make any of these people colleagues could have been correct, because it's very difficult to predict when follicles will ovulate, when perhaps it's small diameter and but relatively soft and a thickened wall, i.e. we've got a little bit of contrasting characteristics. If I had to nail my colour to the mast here, I think this follicle, because of the shape change it's got, is likely to ovulate somewhere in the 24 to 36 hour bracket. But I could be wrong. I would certainly make a note of this in the mare's record. If I made a decision not to get the mare covered or not to inseminate the mare and just checked her, say, in 48 hours, and she had indeed ovulated, very, very important in the mare's record to put a note. This mare may ovulate off a small follicle. So coming back to the scenario, I think I would have to go for being in category 3. I think there's a risk that if we wait longer than 36 hours, this mare may well have ovulated. But I don't know. It's a tricky situation, and it's tricky for all of us. So I thought this might be quite a nice way of drawing out a little bit of a different way of looking at sperm longevity, which is important when we're predicting ovulation. It all depends on having a viable oocyte and viable sperm. And of course, how viable the sperm will be can depend on whether it's a natural cover fresh semen scenario, whether it's chilled semen, or whether it's frozen semen, because the sperm lives a different number of hours stroke days, depending on whether it is fresh, frozen, or chilled. So let's start our scenario with who would breed this mare with fresh semen or natural cover. 60-40 split. Okay, folks, well, I'll tell you, I would very firmly be in the camp that if I monitored this mare, she had a nice open cervix, I saw this 28 millimeter follicle, soft, changing shape, she was standing to be covered, I think, well, you know, we'll cover this mare, because semen lives, natural covering, minimum 3 days, 4, 5, several standards live 6 days. So my point being, why take the chance? We've got a mare in estrus, we've got a mare that will stand to be covered, we've got a follicle which may ovulate in 24 hours. We don't know, but why take the chance? Semen's going to live 3 or 4 days, so get her covered, get fresh semen put in. That's what I would do. So I'd be in the 60% camp. Now, this is a different situation. We're now going to say we're breeding the mare with chilled semen. And you know, I don't know where you're watching or listening to this, but we're based in the United Kingdom. And for us, if we order chilled semen, say 10, 11 o'clock in the morning of Tuesday, we'll get the semen Wednesday morning. So we always operate getting semen the following day. So we're then into waiting at least 18 hours. Say we're looking at this mare, you know, I don't know, 9 o'clock, 10 o'clock Tuesday morning. The earliest under most circumstances we can get semen will be 9 o'clock Wednesday morning. 24 hours on. So 24 hours could see a big change in this follicle. It may be very, very close to ovulation. It may have changed shape even more, may have grown a little bit. But we haven't really that option because we're going to have to make a decision whether or not to order the semen for the next day. So it's tricky. This is a more tricky situation. And I may change into the 60% saying no. You know, this time I'm not going to order the chilled semen. There's cost to ordering the chilled semen. We're just going to have to see what this follicle does because I just don't know whether it's going to hang on or not. It's a little bit unusual. It's a small follicle with some shape changes. So I think, well, I'll sit tight before ordering. But if it was late in the season and or, I'd discuss it with the mare owner. I may say, look, I often, especially our well-educated owners who are always the best ones, by well, I don't mean general education. I mean, knew quite a lot about mare gynecology. I would show them on this. I say, look, we got this kind of conflict here. What are we going to do? Maybe take a punt. This mare may well be ready to inseminate in 24 hours and ovulate within 24 hours after being inseminated. So it could well be the 40% category. Yes, let's order semen for the next day, put it in, and hope she's ovulated 24 hours after putting the semen in. Frozen semen, what do we think now? Who would breed this mare with frozen semen if she had edema and an open cervix? Well, this is good because I definitely would be in the 80% category. Why? Because the frozen semen's sitting in the tank. So what you have got to do with these mares is you've got to put them on an intensive monitoring program every 6 hours because it's so darn difficult to know when this follicle is going to ovulate. We're just going to have to follow her every 6 hours. We've got the semen sitting in the liquid nitrogen tank. When she's gone, bang, we can put the semen in and we know we're doing it within 3, 4, 5 hours of ovulation. So I hope that kind of makes sense for you. Now, I said I'd come back to this. These echogenic particles in the ventral margin of the follicle. Yes, they are a sign the mare is close to ovulation, but they're also a sign of something else. If they become more widespread, therein lies a bit of the problem. What does more widespread mean? If they become more widespread within the follicle, well, then they can be indicative of the mare going on to form an anovulatory hemorrhagic follicle, i.e. a type of follicle failure, which we'll talk about in a later webinar. But for now, I just want to introduce the subject to make this contrast between the normal pre-ovulatory follicle, which does develop some echogenic particles in that ventral margin, with the anovulatory follicle in which they become more widespread. So who amongst you think this mare will ovulate normally? What are your clues? Well, we've got a measurement there, look, 6.05 centimeters. What do we think of that as a follicular size for a thoroughbred mare? It's big. There's no doubt that's large. Is it abnormally large? Difficult to tell. It's unusually large. And it still is a pretty spherical shape to me, that follicle. So I think when you've got a 6 centimeter follicle that looks, we're not palpating it, so I can't give you the palpation information, but the ultrasound impression is not particularly a flattening and is retaining a spherical shape. So I would imagine that follicle palpated pretty firm. And I think those echogenic particles, I mean, you may argue they're not quite dispersed throughout the whole follicle, but they're pretty close. So for my money, I think that mare won't ovulate normally. So it's all a question of degree. Everybody talks about, anovulatory hemorrhagic follicles are when these echogenic particles are appearing. But it's very hard to say with absolute certainty whether a follicle is normal and just getting close to ovulation, or has indeed become a hemorrhagic anovulatory follicle. If we look at some video clips, look, here's a mare. Is that a hemorrhagic follicle, or is it a normal mare? Is it a follicle going to ovulate normally? Look, you've even got this sort of, I presume this would be some kind of fibrin blood clot within it. Is that a normal mare or not? Look at your scale, 9.6. So this is a 1, 2, 3, 4, 5, 6, 7, nearly 8 centimeters, this follicle. Yeah, I'm putting that in the category of anovulatory hemorrhagic follicle. What do we think of this? Absolutely bizarre looking structure. I think in the past, before we had good assays to detect it, we would have said this could have been a granulosa cell tumor. I always blot these, and if these the strands wave, as in this case, you'll see when I take it off frozen in a minute, the strands move around, then I think that's indicative of an anovulatory hemorrhagic follicle, not a granulosa cell tumor. Of course, these days we've got some pretty good laboratory tests to diagnose a granulosa cell tumor, so we shouldn't really make this confusion. But particularly if you don't examine large numbers of mares, you may think, oh, got to be something wrong with this mare's ovary. Absolutely not. It's just formed a hemorrhagic follicle. There's another example of a hemorrhagic follicle, and still quite a bit of these fibrin strands when you blot the follicle, wiggle around a bit, for want of an unscientific way of putting it. That helps me think that they are, it is indeed a hemorrhagic follicle and not a granulosa cell tumor. Just for completeness, I'll put a granulosa cell tumor in here. So they certainly look similar, but on blotting this, there's no movement of these fibrin strands. They'll be pretty, so much more solid looking structure. As I say, these days we can generally diagnose them with AMH tests or inhibin, and hopefully we shouldn't confuse the diagnosis. So let's deal with a little bit of the follicle evaluation. The other important facet we use when we're predicting ovulation is endometrial edema. And much has been written about this. I like the two papers a good friend and colleague of mine wrote, Juan Sampa, these in the AAEP proceedings. 97 really was Juan's paper introducing this concept that we could grade endometrial edema with a score or a term, you know, moderate, slight, or 0, whatever you're going to grade it, but grade it somehow. And as the mare moved through the follicular phase, the endometrial edema score would rise to a peak a day or so ahead of ovulation, and then begin to decrease. That was really the subject of the 97 paper, which many of you will be familiar with. And 2007 was really an interesting paper with a different take on the edema subject. It was looking at the endometrial edema pattern in abnormal mares. So I'd encourage you to have a read of those two proceedings, which you should be easily able to get online. I'll try and summarize them and explain how endometrial edema can be used in routine gynecology. Our system is, we used a numbering system, so 0, 1. And this is what we would call endometrial score 1, E1. Now, you know, what you might call it something else. It does not matter, because it's a relative diagnosis. So whether you call it a 1 or call it a 2, it doesn't matter. It's as long as it's relative to you. You're looking for the increase and decrease. We would call this a 1. We'd probably call that a 2. Call that a 3, or even a 3+ if you want to call it. I know some people do. And that would be, you know, uterine edema score 4. And that's as edematous as a uterus gets. So whatever system you're going to have, grade the edema pattern. So that would be 1 and that would be 3. Why is it important to grade it? Because when you're at this most intense edema pattern, the important thing I think to remember is that's the point at which mares will respond most consistently to your ovulation induction agent, be it deslorelin or be it HCG or whatever. You should aim to give your ovulation induction agent, usually be with a follicle 38 millimeter plus, but this marked, this grade 3 out of 4 edema pattern. That's when mares will respond most consistently to an ovulation induction agent. Now, I don't know if these mares trouble you. They certainly can trouble me. They're a mare which, throughout the follicular phase, develop no endometrial edema pattern. So I asked people, I said, what percentage of mares have no edema pattern in the uterus at any stage of the follicular phase? And I would be in the majority again here. I think it's less than 5%. I think it may actually be somewhere like 1 in 100, 1 in 50 at most. So 1 to 2%. So not 0. So I wouldn't be in the 0 category. I do occasionally see it, but it'd be certainly even less than the 5%. So I think it's pretty rare. What do I think when I see a mare with no edema in the follicular phase? What I wonder sometimes is, if I've been entirely correct in assuming she is in the follicular stage, I just wonder if, and it's a concept a little bit hard to explain in a webinar when I can't actually be there or show you in a mare, but I think it's where the corpus luteum doesn't lies completely, but it's very hard to see. But there's maybe a trace of luteal tissue. So when I have a mare where the follicle is growing, 25, 28 the next day, 31 the next day, but no edema patterns in the uterus. Cervix, I think it's opening, a bit hard to tell. We may have teasing information, which may be inconclusive. We may not have teasing information. I will give those mares a very, very, very low dose of prostaglandin because I'm thinking there's some luteal tissue here. I just can't see it. And very often the next day, there's a very marked edema pattern in those mares and everything's back to normal. So I think it's extremely unusual. A very small percentage of mares have no edema in the uterus at any stage of the follicular phase. Is it normal? That's an interesting question. Is it normal for a mare in the follicular phase to have no edema? Well, I think I think it is abnormal. I think if you get no edema throughout the follicular phase, it is abnormal. We did a paper way, way back when I was at the university in Utrecht, and we measured progesterone and estrogen levels. And when we had a basal progesterone level and a high estrogen, any mare that didn't display edema, we were able to look at the oocyte. It was poor quality. Basically, we consider that cycle to be abnormal. So failure to detect endometrial edema as a mare progresses through the follicular phase, it's not normal. So it could be there's a remnant of luteal tissue there. So I would urge you to do the little injection of a very tiny dose of prostaglandin. But if you still don't get any edema, I would usually let that mare, I'd keep monitoring her. She may go on to ovulate, still no edema. If that is the case, I make in big bold notes in her record, this mare may ovulate with no edema developing. Then at least the subsequent cycle, we think, well, hey, this is this mare, so we better go ahead and inseminate her. Mares that ovulate with a marked edema score, and this was really what Juan Samper talked about in his 2007 paper. Mares that ovulate with a marked edema score should be considered possible windsuckers, pooling urine, i.e. the uterus is getting irritated by something, and that in itself will cause an endometrial edema pattern. And the mere fact that they are susceptible to fluid accumulation Obviously, edema is fluid within the tissue. If it becomes actually free fluid in the uterus, susceptible to fluid accumulation in the uterus, well, it's only one step back from that to have endometrial edema. So mares that ovulate with a marked edema score, as we know, in most cases, the edema score's lessening in that 24-hour period preceding ovulation. Consider them as windsuckers, urine poolers, possibly susceptible to fluid. You've got to look at all those three aspects with them. A couple of exceptions I want to mention. Don't know if any of you can think of them. Mares given deslorelin. Deslorelin does have the ability to drive the follicle to ovulate, and there may still be quite a marked endometrial edema pattern at ovulation. And the same with foal heat. Mares, which that's another story whether you should or shouldn't cover at day 9, 10, 11. But anyways, if you're breeding a mare at the foal heat, first estrus postpartum, don't sit around and wait for that edema to decrease ahead of expecting ovulation. Mares at the foal heat, in our experience, will quite often ovulate with a marked endometrial edema pattern. And here's data from really the papers of Sampa graphically illustrated. SH is just standing heat, and OVD is ovulated. Here would be the normal pattern. Over 4 or 5 days of follicular phase, edema increases to a peak. This is when you should be giving your ovulation induction agent. Then in the 36 to 48 hours prior to ovulation, decreases back down again. Not so in your abnormal mare. That may be a windsucker, may be prone to fluid accumulation. Yes, they may still be on a decreasing edema pattern, but overall, much more marked endometrial edema. So just learn to interpret your endometrial edema scores with a little bit of caution, thinking that they can be significantly greater in your inverted commas abnormal mare. Ovulation, relatively easy to detect. A large non-echogenic follicle, black, if you want to put it that way, anechoic, all these slightly confusing different terms you get, rapidly replaced by a highly echogenic, so white, early corpus luteum. This is a mare with 2 follicles. I just picked it to help illustrate it. So 2 pre-ovulatory follicles up in that image. The next day, one of them had remained, one had ovulated. It can be difficult to detect the very fresh ovulation. Hasn't really had time to organize, form an obvious corpus luteum. But there you can see it, but an indistinct structure. And then if we went back the following day to this mare, a bit more obvious. We can see there we've got the 2 corpora lutea. On that subject, it's a good idea to get used to looking at number of ovulations. Here we've got three ovaries from mares with one CL, 2 CL, and 3 CLs. I don't know if you can identify them. Yeah, it's a little bit hard because you haven't got a video clip of it. But this bottom right would be the 1 CL. Let me go back. Sorry. This bottom right would be the 1 CL. This is 2 CLs. Sort of one there, and one up there. This is 3 CLs actually. One there, and one there. So, like I said at the very beginning, important to get used to looking at number of CLs. Early CL, very recent ovulation, can be difficult to see, look. Bit indistinct. You know, I've outlined it there. Hasn't really had time to collapse and form. Many forms of the early CL, and that poses a challenge in identifying an abnormal ovulation, which we'll talk about. We'll have a separate webinar on hemorrhagic follicles. There are many forms of the early CL. It can be pretty solid. Look at this one on the left. That's a pretty solid structure. On the right, look, this kind of big lacuna, anechoic hole in it, for want of a better word, and larger than the one on the left. But both are just normal early CLs. Here's another couple of variations. Quite a thin border only of luteal tissue in this one, but it's still a normal corpus luteum. And then here, much more solid structure. So very, very difficult to pronounce abnormality as regards the corpus luteum of the mare, simply because there are so many different appearances of it that it becomes hard to tell. And this, of course, leads us on to this very important topic of ovulatory dysfunction. We were lucky in the current therapy book I wrote with Juan Samper and Angus McKinnon. We got Pat McHugh, a good friend and expert clinician, to write the chapter on ovulation failure. And in Pat's chapter, he put 8% of cycles. So what does that tell us? Well, it's a really common problem is persistent anovulatory follicles. And I recently had a chance to go chat this through again with Pat, because I felt, and he agreed with me, that probably this figure could be revised slightly upwards. I think round about 10% of mares per cycle develop a persistent anovulatory follicle. So point being, this is a really important condition as a veterinarian to diagnose. And I think on that, for that reason, we'll have it as an entire separate topic. Just to introduce here the two figures, 8% of cycles, but with the caveat that it probably is nearer 10% now. The vast majority look luteinized. The vast majority form luteal structures. They're anovulatory because the oocyte is not released, but they are luteal structures. A very small percentage may even be, whether it's 90-10 or 85-15 is here, whatever. But a much smaller percentage would be the important thing to remember, form a persistent follicular structure. So this gets larger and larger and larger, but just doesn't ovulate. They're a little bit more difficult to deal with, as we'll mention when we come to that topic, because of course the luteal structures you can give prostaglandin to. Prostaglandin to these 15% that remain as follicular structures, can't do much about them. With that, I think we'd better finish, and I hope you enjoyed it. I hope it's been a fun run through the subject for you, and informative. And if you have any questions, we'll do our best at some stage to answer them for you. So with that, thank you very much.
Thank you, John. Any questions that you have can be submitted to hello@imv-imaging.com. You will receive an email in the coming days with the full recording of the webinar, and this can also be found on our website. We will also provide information on how you can join the next webinar in the series, the use of ultrasonography to detect pregnancy in the mare. To access our full range of learning materials, visit our website imv-imaging.com/international. Thank you for joining us. Goodbye.